Hey y'all, I'm gonna record a quick video here for you covering post-term and meconium-stained fluids, post-term deliveries. So we call a pregnancy post-term if she's 42 weeks. Of course, 40 weeks is due. That's her due date. If she delivers anywhere in that 40th week, then that's pretty good. It's kind of rare for somebody to deliver right on her due date. But anywhere in the 40th week is, common, expected, good, fine. By the time she's getting 41 weeks, the provider, doctor or midwife, is going to start going, I think we should look at you needing to be induced very soon. Because by 42 weeks, the risks go up for mom and for baby. So let's look at these and look at why. Risks to mom are dysfunctional labor, perineal injury, hemorrhage, infection, and an increased incidence of C-sections. So all of these could be attributed to if you keep that baby growing and cooking 2 to 3 weeks longer than, you would expect, this baby keeps growing. Well, now we have a big baby. We're at risk for tears. We're at more risk for hemorrhage because remember, if our uterus is expanded even more, then it's like a stretched out balloon and it's not as likely to easily come back down to size. We tend to have uterine atony, a tone, no tone. Okay. So, which is the biggest, most common cause for postpartum hemorrhage, right? Now, so we've got a risk for hemorrhage there. We've got the risk for perineal injury. Again, same type of reason for dysfunctional labor as well. The uterus is just stretched out. Okay. Increased risk for C-section, partly because the risks to the baby go up, which we're going to talk about too. So risks to the baby are abnormal fetal growth. This baby keeps growing, keeps cooking longer and longer, keeps growing bigger and bigger. Macrosomia, right? A baby is macrosomic if they're in the greater than 90% percentile on the growth charts. Rule of thumb is about 4,000 grams. So if we suspect, and we can get a pretty good idea on ultrasounds, they're not 100% accurate. And, the provider will be using Leopold's and try to estimate the size of the baby. But if they suspect that the baby's getting very big, they might recommend a C-section right off the bat. Because again, it puts the mom at greater risk for perineal injury and puts the baby at risk for shoulder dystocia with a macrosomic infant. Other things, birth injuries, that would be shoulder dystocia, the brachial plexus injury, because when a baby gets stuck in there and the provider's, possibly pulling on the neck, the shoulders stuck behind the pubic bone there, we're definitely at risk for injuring the baby. Other risks, oligohydramnios. By this point, which is the next bullet point there too, our placenta is getting old. It's not working as well. It's not working to exchange oxygen and nutrients as well between the baby and the mom. So we start seeing possible signs of hypoxemia in the baby or hypoxia. Cord compression because of oligohydramnios, right? There's not as much space. The baby's growing big and the fluid pockets are smaller. So we are at risk of pinching the cord every time the baby moves or rolls or, kicks or just comes down, especially once the mom's water breaks, then there's even less fluid in there potentially. So just less room for the cord to live freely without getting pinched, right? So oligohydramnios is a risk there too. Placenta's getting old. We can often see this in the baby's heart rate. So we're looking at heart rate on the monitor constantly, especially if she's overdue and this post-term. This mom's going to need more frequent monitoring because we know that the risks are increased. But it's not uncommon to see more decelerations, to see less variability, so less squiggly. The line's a little bit flatter there. And when this happens, this could be a sign that the baby's getting stressed. So if the baby has a stressful incident, it might have happened even before they came in to the hospital to be monitored, but sometimes we can see it on the monitor too. If the baby gets significantly stressed, it's very common that they will pass meconium in utero. So the other side of the slide here about meconium-stained fluid relates to this bottom bullet point on the left side about meconium aspiration. So meconium-stained fluid, the baby has passed meconium in utero, which basically means that the baby has been stressed. And there's a vagal response that relaxes the anal sphincter. You think, you might have heard about this like with adults too. If a person dies and you hear about just everything relaxing and they end up passing stool on themselves. Same kind of idea with the baby. They might have had an incident, a hypoxic incident where the cord was pinched, or they had this something happen that we might not know about because they might not have been on the monitor, where they had a period that oxygen was decreased. Baby had a vagal response and passed meconium. So meconium-stained fluid. Meconium to us, like when the baby is born and they pass their first stool, this is the one where we say it's very thick and tarry and black. And it looks like tar oozing and bubbling up. If you watch a baby pooping meconium, it's like a bubble of black tar looking. But when they pass in utero, and if you see it diluted like this in fluid, it looks black to us, but it's actually green. It's a very dark green. And so meconium-stained fluid is green. We could have thick meconium, where there's been a lot of meconium passed, and literally instead of a gush of clear fluid, we have pea soup oozing out. So it's thick and very, very particulate with green mashed peas is kind of what it looks like in the color. You can also have thin meconium, where there's not a lot of stool pass, there's not a lot of particulate matter. It's just a thin, it's basically very liquid, but tinged green. Maybe has some flecks of solid matter in it. Thick meconium is obviously much more of a risk, but thin meconium is as well, because any amount of stool that the baby is then at risk for aspirating, because remember, the baby is constantly swallowing amniotic fluid and then peeing it out again, swallowing and peeing, swallowing and peeing. And so they're doing the same thing with meconium fluid. They also have this fluid filling their mouths, filling even their lungs when they're born. So it's a risk, meconium aspiration, that especially when the baby takes its first big deep breath and fills its lungs, that if it has that meconium in there, then they could have this severe form of aspiration pneumonia and or respiratory distress. So these are all risks of preterm deliveries, and a reason that we encourage, usually, the provider is going to try to get the mom to either come in for an induction or to maybe try some methods at home to help encourage her body to start into labor, which is another mini video that we will talk about later. Thanks. See you next time.